educate general dentists, and this whole program is designed with the general dentist in mind, not really the endodontist. And so a portion of this presentation that I'm doing for you is where we get to discuss the irrigation methods and what are the right protocols and how do we approach things. And I know that you probably are going to get asked these questions when you're in the field. And for those of you who don't use these on a daily basis, like somebody like me, you know, I want to kind of walk you through what our protocols are. We want to talk about the way that we do things. I can go through this little slide deck and just kind of try to explain things to you. And I love questions, so you know, feel free if you have questions towards the end here that we can come back, we can revisit. My whole goal is to give you enough information that when you're in front of a doctor, you can hopefully answer some of the questions that he might ask or she might ask you. I think it's really important as we go through endodontics that we always put so much emphasis on the way that we do endodontics, in the sense that we use certain file systems and we use a certain protocol. It's almost as if we follow a cookbook of how to kind of clean or how we shape a canal. But in endodontics, sometimes we almost don't spend enough time on how do we really clean the canal itself, because it's really important to understand you can create any type of a shape you would like with rotary instrumentation. But the whole key is you still have to clean it, and that takes an irrigation protocol in order to clean the inside of the canals. And what do I mean by that is that if we really kind of look at all of everything, if you look at the canals itself, there's so much to a canal system. Pardon me. And you know, we have to be able to, can we, you know, clean the little fine channels in between canal systems? Can we clean and, you know, what we call lateral canals and apical deltas and all these types of different things that our instruments just cannot reach? And so that's the whole goal of irrigation, is to see if we can get into these places that our instruments can't touch, that hopefully we can, you know, clean the insides of that. And the only way that we can do that, of course, is through irrigation. So there's always ideal properties of irrigants. Ideally, we want something that's not going to hurt the patient. You know, we don't want to cause problems beyond the end of the root. We don't want people to be allergic to stuff that we use. We'd like it to be able to kill the bugs that we're trying to deal with. And there's so many bugs. You know, there's over 600 different strains of bacteria that we've been able to identify at this stage. But we know that there's a lot more that we just don't have the capability of identifying. Most importantly, can we dissolve this pulp tissue that's still on the inside of the canal system? And, you know, those bacterium that are inside of the canals will always put off what they call endotoxin. And this is residual stuff that's kind of left behind that could potentially cause a problem further down the road. So we want to be able to try to eliminate these endotoxins. And then, you know, we'd like to get rid of the smear layer itself, which we'll cover a little bit more. Problem is do we really have anything on the marketplace today that ideally we can use one solution to eliminate and to take care of all these issues? And we really don't. We don't have a single solution that's available for us today that would handle all of these issues. So Ove Peters basically has come out and said, you know, it's the frequent irrigation that's necessary to flush and remove the debris that's generated by cleaning and shaping the canal systems itself. Therefore, we need to be able to use this interaction between cleaning and shaping and irrigation. So that means that we have to be able to clean and shape with our files, and we have to be able to go in and rinse everything. And that's the way, and that's the method that we have available for us today. So what are our goals of irrigation? Well, if we really look at the inside of canals, you'll notice there's all kinds of things on the inside of a canal. We've got pulp tissue, so we've got to be able to dissolve pulp tissue. We've got to be able to remove the smear layer. We've got to be able to kill the bugs. So if we look, you know, microscopically, there's all kinds of things going on the inside. And so we really ask our irrigation materials to do a tremendous amount for us. So there's two methods that we have today which we try to introduce irrigation into the cleaning process. And one method is what we have, passive irrigation, and the other method is what we term active irrigation. So what is passive irrigation? Well, passive irrigation merely means that we're just adding some type of solution inside of the tooth itself. We're really not taking it down the roots of the teeth, but we're really putting it in what we call the chamber of the tooth. And that's basically just kind of adding solution on the inside of the tooth, just to the chamber, and we're kind of relying on our file instruments to take this solution down, but really it's not effective at this method. It just doesn't work. You know, you got the inside of the chamber nice and clean, but it really doesn't do much for the roots. So because of that, we have to start thinking in terms of what we call active irrigation. And this is where we actively introduce an irrigating solution into the roots of this tooth itself. And whether we're using a syringe with needle tips or whether we, do it through ultrasonics, the whole key to this is that we have to constantly keep adding solution, and we need to keep this solution in motion. So we're constantly irrigating, and we want to introduce the solution as deep as we possibly can. And so when we look at what is available for us, the majority of most clinicians will use a needle tip. And so when we look at needle tips, there are two types that are on the market. There's one type that's called a slotted end tip, and the availability is either 27 gauge, 30 gauge, and they're traditionally, it's a large quantity, 100 in a bag. Or then we have what we call side ported tips, which is basically it's a closed end where it's got a little port on the side. And I think the key for us here is, let's see if I might have frozen here. There we go. All right. The whole key is we want to be careful when we're using slotted end tips. Slotted end tips have a potential of extruding enough irrigation beyond the end of the root and into the periapical tissues. So therefore, we tend to shy away, as endodontists, we tend to shy away from these slotted end tips, and we really like the side ported tips itself. So if you kind of look at a closer view, you can kind of see what we mean by that. We want to try to get our working length within 1 to 2 millimeters of our working length to get our irrigation down in that. And then if we can express the irrigation material, we don't want to force it out the end. It's easier to come out the side. So clinically, this is kind of what we're looking at trying to do. So we always recommend that you may want to consider using a 30 gauge because 30 gauge needle tips are smaller and they can get a lot deeper. We try to take it within 2 to 3 millimeters of the working length. We try never to obstruct it. And what that means is that we don't want to force the needle tip to where it engages the walls of the canal to where we don't have any movement on that needle tip. Because if we were to engage it and obstruct and then we express, then we're going to get those sodium hypochlorite accidents that are never real enjoyable. So we don't want to force the solution. And, on needle tips, they're available steel, nitrile, and flexible. And the whole key is you got to keep the needle tip in constant motion as you express your solution. So I always like to pretend I've got Parkinson's disease and I just shake my hand the whole time. So that way I'm not obstructing the canal and I've got free movement of the needle tip within the canal system. There's a new one that's on the market just so that you're aware of. Now, this is called an Irriflex. And this Irriflex is out of Switzerland and it's being marketed by Dentsply Tulsa now. And it's part of their George Bruder's new, well, it's not a new file system, but it's the one that they're marketing now. And unfortunately, it's escaped the name of me. But this is actually what I have started using because it's got a side ported tip in 2 different directions. And this flexible plastic tip can actually get much deeper into the canal. So I think I'm really getting my solutions much deeper. But you'll probably run into this, and so you just need to be aware of it. But this is where most of a lot of the irrigation is starting to kind of flow into is this Irriflex tip. There's also what we call acoustic streaming, and this is more of a sonication. It's a shock wave in the sense where you kind of utilize your ultrasonic. And so if you put an ultrasonic tip on your ultrasonic handpiece, then you introduce your solution, then you take your ultrasonic handpiece down into the canals and you activate it by turning on your ultrasonic device, then you get much more movement of the actual solution itself, but it also allows the formation of free radicals. It oxidizes the hypochlorite. It was really thought of cavitation at one time, but now we're mainly calling it sonication. It's just the movement more rapidly of solutions that you can't really get just by a needle tip or, you know, the Airflex or whatever it is that you're using. But if you look at it clinically, so what you're really looking at is an ultrasonic tip in the middle, and then you can see the sound waves and the waves of the solution in and around that whole needle, and you can see how it disperses laterally, you know, in all directions. So therefore you get a much more rapid movement of the particles itself. And so that helps to clean the inside of the canal quite a bit. And it's controversial in the sense that some clinicians will think it is not as useful and others will think it's the best thing ever. So I always tell a clinician, it's your choice. You know, you're the clinician, you make the determination. Do I use this in my own practice? Oh, absolutely. You know, especially on cases that are necrotic with large lesions. I use it pretty much all the time on retreatment cases because I can dislodge, you know, even remaining particles of gutta percha that my files couldn't remove. And then there's what we call this manual dynamic agitation. And what this term really means is that if we don't use sonic irrigation and we're not doing really great with needle tip, you can take a master cone that's fitted to your working length, and you can place solution inside of the system itself. And then what you do is you basically pump manually this master cone up and down, up and down, up and down, and that'll help exchange solutions on the inside of the canal. But you know, it takes time, as you know, so we're talking about 2 minutes, but just that motion itself can bring the irrigation material down to the working length, and we can try to exchange solutions that way. There are advantages of sodium hypochlorite, and this is why we use this, you know, because it will dissolve vital pulp tissue, it will dissolve necrotic pulp tissue, it kills the bugs, it acts as a lubricant for the files, which is what you always need. You never want to take a file inside of a canal when it's dry. You always want to have some type of solution on the inside. And most importantly, it helps flush out the garbage that, you know, is left over from doing all your cleaning. But with anything, there's always disadvantages. And the biggest problem and the biggest knock on bleach or sodium hypochlorite is that there's a cytotoxicity if you get it beyond the end of the root. And if it gets into the periapical tissues, then that can develop some problems where we'll get what we call the sodium hypochlorite accident. And that's an immediate response of the periapical tissues where you'll get pain, you'll get profuse bleeding, and that bleach will actually kill the cells, you know, in and around the bone, and it's not real enjoyable. The key is, you know what, it's manageable. Patients do recover from it. They may not like you a whole lot for a week, but they do recover, they do heal, and normalcy does return. But that's the whole goal. We don't want our bleach to go beyond the end of the root. And that's why we really stress the side venting, because that's what we're trying to reduce, and that's what we're trying to prevent. And with inslotted, you have a much higher incidence of this occurring. In terms of the needle irrigation, you know, I do a lot of needle irrigation. I do use the Canal Pros in my office. I love the color coding. I can look at the color, know exactly what's my solution on the inside, and it makes it very easy for us in our office. But the key with any type of needle irrigation is you have to make sure that your syringe has a lower lock system, because you have to be able to physically lock that needle in so that as you apply pressure to try to express your solution, you don't blow the end of the needle off, and then, you know, Mrs. Smith's beautiful black blouse now becomes a beautiful white blouse. So you have to kind of make sure that you've got that needle tip in, because you just don't want to disengage that tip. I personally like the smaller ones. I use the 5 cc's. It just fits better in my hand. It's easier to express, but that's just a personal preference. So, you know, you might have some clinician that's got big old mitts, and, you know, they may want, you know, the 10 cc's. That's fine. You know, just whatever works best is in your hands. The AAE has a position on sodium hypochlorite, and the problem is that we all love to go to Costco, and we all love to shop there because we think we get great bargains. Well, the problem with Costco is that, you know, if I go to Costco and buy my Clorox, let me see, it's a 3-gallon size, and boy, I'm really lucky because I can get 3 bottles of 3 gallons. So I've got 9 gallons of sodium hypochlorite. That's probably more than my entire career that I would ever use. And the problem is that every time you take that cap on and off, you expose it to light and to air and everything else. And so over time, the efficiency and the efficacy of the sodium hypochlorite is going to degrade. So we always try to tend to say, you know what, you may not want to run Costco to get those great big bottles of bleach, because it's not going to be effective for you long term. It's going to lose its ability to clean and dissolve and do the things that we ideally would like it to do. So I always kind of talk in terms of trying to get smaller sizes, so that way, as you get smaller sizes, your material stays fresher. I do tell the clinicians there's all kinds of sources of that. I tend to try to advise them to stay away from, you know, the small quart-sized bottles of Clorox. The beauty is with the sodium hypochlorite, you know, you can either get it in full strength or half strength. Now, I'm not a huge fan of the half strength. I tend to like my full strength more, and it really has to do with the time of the solution in contact with pulp tissue. And what do I mean by that? Well, if I'm using full strength, it takes less time to dissolve pulp tissue than if I were using a diluted strength. And so here's a nice little, whoops, hang on, let me go back. I want you to see this clip. This is a nice little clip that actually shows this in process. So if I dilute my bleach or if I go full strength, I want you to kind of notice that the amount of time it takes to dissolve pulp tissue. So of course, you know, we've got this speeded up here a little bit. Mohammed was nice enough to send me this little clip. But you could see how within a minute in full strength, the pulp tissue is already dissolving, but at the diluted strength, it's still pretty present. So the whole key for me personally is I use full strength in everything because it's less contact time. Back in the 70s, they advocated diluting the bleach because they felt if they diluted the bleach that there would be less incidences of sodium hypochlorite accidents. But the problem with diluting it is you can still see, you know, the amount of contact time it takes to dissolve that pulp tissue. At full strength, we were just a shade over a minute for it to dissolve, and we're almost at 5 minutes with the diluted bleach before we can even get the pulp tissue to dissolve. So therefore, I like full strength. And if that doesn't work, there's always this. Think about this, you know, full strength really does work. Anytime that you take an instrument inside of a canal, you're always going to create what we call a smear layer. And this is basically a layer of debris against the inside of the canals itself. And so what is this smear layer? Well, it basically consists of the dentinal shavings. It consists of cell debris, it's pulp remnants, you know. And the problem that we have is if we go into a tooth that's necrotic and it's got endotoxins and bacteria in it, if we go in and clean and shape and we create this smear layer, well, the bacteria is going to be stuck against the side of the root, and now we put down this smear layer, which acts like a blanket over it, and it protects that bacteria and it keeps it against the wall roots. And so that's not always a good thing either. So we definitely advocate removing the smear layer before we want to obturate. And the reason is because we have to get rid of the bacterium and the endotoxins and everything that is against the cell or against the canal wall, because we don't want a potential problem of bacteria regrowth. We also want our sealer to contact the walls of the canals itself so that we can ideally get it to go into lateral canals and dental tubules. And there's some evidence out there that says that the smear layer could, you know, actually interfere with the action and effectiveness of our root canal irrigants and things that we use in our appointments, you know, such as calcium hydroxide, other things. So how do we realistically remove it? Well, we use a product that I'm not even going to try to pronounce, and we all call it EDTA. So it's a 17% EDTA. This is a high viscous solution that we want. This is not root RC root prep or any of the gels of EDTA that are on the market, the concentration of EDTA in those gels is much lower, and that product is designed specifically as a lubricant and not as a smear layer removal. So if you're going to remove smear layer, it's just important that you have the 17% EDTA that has it's in solution, because that's how you have to carry it into the canal systems. You can't carry gel down. Kalk's study in 2000 indicated that the maximum recommended time of EDTA inside the canal system should be 1 minute. You really don't want to go more than 10 minutes, because if you go longer than 10 minutes, you excessively remove both your peritubular and intertubular dentin. And if we can remove the smear layer, there is that evidence, especially from Kalk's paper, that shows that we have a better adhesion of our sealers to the dentin and we get better penetrance of the sealer into the tubular areas and our anastomosis and those things, that this is the places where we want our sealer to go. So what is the smear layer? Well, this is Marcus Hopalop's study out of Vancouver, where in cross section you'll see this picture, and up at the top what you're looking at is the actual smear layer that's created. So that's like a blanket of material, and then below that you're seeing these little channels, and that's the dentinal tubules, and you can see how far down into the dentinal tubules the smear layer can actually get into. And what we're really trying to do is we want more of a clean look. We want to be able to remove that smear layer so that we can actually see these dentinal tubules. And so we use our EDTA to open that up, remove that smear layer, because that's ideally the look that we're looking for. So again, EDTA is available in all different methods, and I always tell my clinicians, you're the clinician. There are many corporations out there that will readily make EDTA available to you. This is the EDTA I like, this is what I use, and I kind of let them make that decision. But the beauty is this is the type of EDTA that you want to use, not the Pro Lubes and the RC preps and that type of stuff. So how do we do this? We talk about all these solutions that we want to use, but how do we teach our clinicians the methods? Because you can put 50 general dentists in a room and they're going to have 50 different ways to do things. So typically our protocol would be utilizing both sodium hypochlorite and EDTA, and for me this is on vital teeth. Now if I have a tooth, so what I do is I go in and I introduce my bleach throughout the entire time I'm cleaning and shaping. At the very end of the process I add my EDTA. Well, the problem is most clinicians want to go, okay, well I need to rinse my EDTA out, so I'm going to go right back in with bleach and I'm going to rinse it back out. Well, I kind of have to advise against that, because if you look at Marcus's same study from 2010, he showed that if you went back in with bleach after you used your EDTA, you're going to cause an excessive erosion of the canal wall. Well, what does that really mean? Is that a potential of weakening the root? It's a potential. How do we really prove it? All we can do is prove it on the microscopic level. So the whole key is you don't want your clinician to rinse with bleach, then do his EDTA rinse, and then rinse again with bleach to get rid of it. There are other things that you can use, sterile water, and you don't necessarily always have to rinse the EDTA out. You can go in and just suction it all out and dry it out that way if you choose to. Some clinicians will use ethyl alcohol, which is a medical grade. It's not isopropyl alcohol, but it's ethanol, and they can rinse it out, and that will help dry out the canals as well. So there's all kinds of ways to do things, but just stress, don't go back in with bleach after you've already done your EDTA. So again, we talk about if the tooth is vital, we go in and we use our bleach throughout the entire cleaning and shaping process. The very last step after we have fitted our working length cones, then we go in and we do a 1 minute rinse with our EDTA. We let it sit, we evacuate it, and we obturate. But if that tooth is necrotic, here's the thing to think about. Now on a vital tooth, there is no bacteria in the tooth. All we're really working with is tissue. And we've already showed you that bleach will dissolve the tissue. I don't have bacteria on the inside of the tooth on a vital case that I have to worry about residual bacteria possibly reinfecting. But if I go into a tooth that's either been treated and I'm doing a retreatment, or a tooth is necrotic, now I'm dealing with bacteria on the inside of the tooth. And if I go in and do my cleaning and I create the smear layer and I get bacteria that gets caught against the cell or against the canal wall, I still have to get that bacteria out. Well, I've already just mentioned to you that if I go back in with bleach again after EDTA, because remember, EDTA removes the smear layer. Well, if I go back in with bleach, then I can excessively dissolve more of the canal that I don't want to do. So I want dentists to start thinking about chlorhexidine as a final rinse. And so what you do is you use your bleach throughout the whole system. You get your, you get your master cone fit, you do your 1 minute bleach, or your 1 minute EDTA rinse. Well, now you can go in and rinse the EDTA chlorhexidine. And the reason that we do this is that, remember, EDTA will remove your smear layer. Once the smear layer is gone, we've got bacteria exposed again. Well, I've already mentioned to you, if I go back in with bleach, I'm going to excessively erode the canal wall, and I don't want to do that. But if I use chlorhexidine, now I've got a safe method to go in and get after the bacteria that's trapped underneath of that smear layer to remove it. So what is our chlorhexidine? Well, chlorhexidine itself is a broad spectrum antimicrobial agent that's really good against both gram-negative and gram-positive bacteria. It has very little toxicity. We can get this beyond the end of the root and have very little inflammatory cell response to it. But the beauty is it still has that same antimicrobial action that's similar to full-strength bleach. And it's actually found to be more effective against E. fascialis, which is a bacteria that is most commonly associated with endodontic lesions. But as with anything, there's always disadvantages with chlorhexidine. The problem with chlorhexidine is it doesn't dissolve necrotic pulp tissue itself, and it doesn't remove the smear layer. And so for those reasons itself, I can't use chlorhexidine as my sole irrigant. It has to be used in combination with sodium hypochlorite. Again, it's available in all types of methods. This is my chlorhexidine choice. I like being able to get chlorhexidine that is from a manufacturer because I know there's going to be quality involved. This is not the same chlorhexidine that you would see in what they call PerioGuard or a lot of the oral mouth rinses. So if you've got a clinician that just says, I just use Paradex, yeah, doc, that's not quite the same stuff. It's got different things in it, and it's not used. It's not recommended for use. There is a big problem though that you have to be careful about with chlorhexidine and sodium hypochlorite. When sodium hypochlorite and chlorhexidine come in combination with each other, they form this kind of brown-orange precipitate that's called perchloroaniline. And this perchloroaniline is this precipitation that is so hard to get out. And once you see it, you know immediately what it is. And that occurs when a clinician goes in and they're using bleach, and then they decide that they're going to go in and rinse the bleach out with chlorhexidine. And that's when that problem occurs. That's why we use EDTA, because EDTA actually will neutralize the sodium hypochlorite. So if you go in with bleach and then you follow it up with EDTA, you've neutralized the bleach. Now you can safely go in with chlorhexidine after this, and you will not get this perchloroaniline that is formed. So again, stress that we don't use these ones right after each other. So this brings up another thing. So what about these two products that are on the market that you're going to get questions about? What about Smear Off and what about Q-Mix? Well, these two products that are out there on the market are basically a 2-in-1, meaning that they have both EDTA and chlorhexidine together. And honestly, I use the Smear Off. I've used chlorhexidine in the past. I like the simplicity of the Smear Off. There's actually studies out there from 2015 that actually shows that there's fewer inflammatory, there's a less inflammatory reaction by using either a Q-Mix product or a Smear Off product over just straight chlorhexidine. So you'll probably get this. I have no problem with either one of these two products on the marketplace. One's a little cheaper than the other, but it's really just dependent upon what the clinician wants to use and how they want to do things. And I personally don't have a problem with this, but as a clinician, you know, they have to make that determination. Okay, so let's review kind of what we've talked about here. We've discussed with sodium hypochlorite that it's an antimicrobial, antibacterial. It kills your bacteria. It dissolves your organic material, dissolves the pulp tissue, all the collagen, all that stuff. So this is your organic dissolvent. EDTA, very mildly antimicrobial, very mildly antibacterial. This is your inorganic. So this is your chelator. This is what removes the smear layer and the inorganic material on the inside of the canal system itself. We've discussed that chlorhexidine is a broad spectrum antimicrobial, antibacterial. The nice thing about chlorhexidine is it's kind of like residual fluoride in the sense that it has the sustainability that can release residual chlorhexidine for approximately 2 months. Again, the disadvantage with chlorhexidine, it doesn't dissolve your pulp tissue. We're all familiar with the Surgi-Tips for evacuation. Great product, gets very deep. You can get to working length with these. You can bend them. You can get all the way down, and very easy to evacuate your solutions. And I think that's pretty much it. So at this stage, hopefully I didn't lose anybody. And if you've got questions, you know, we can unmute, and would love to take your questions. And we're all asleep.
Does anyone have any questions for Dr. Gray?
Yeah, I do.
Shoot, well, you know, when you ask a question, just tell me who you are, and then that way we all know. And you know, or if you want to really be anonymous because you don't want to embarrass yourself, that's fine too.
Hey, Rick, it's Don. Can you hear me?
Yes.
You know, we use the term necrotic, and I understand necrotic tissue when you go in and you retreat patient. When you use the term necrotic, outside of that, like you go in, patient comes in, they need a root canal.
Uh-huh.
How does I guess what I'm you use the term like if you're treating a vital tooth, which I'm a little bit confused. I associate vital with still alive.
Yes. Yes. So here's the definition of both, okay? You're 100% right. A vital tooth is that tooth that's still alive, that if I put cold on it, the patient will feel it, okay? So I know that there's vital nerve tissue on the inside, and that nerve tissue traditionally will have a blood supply, and more importantly, if I open it up, I'm going to see tissue on the inside of that. When I use the term necrosis or necrotic, basically what's happened is that the nerve itself has died, so that there is no longer nerve tissue on the inside of the tooth, and there's no longer a blood supply on the inside of the tooth. This is that tooth, if I put cold against it, it's not going to feel the cold. So we use the term necrotic, meaning necrosis, meaning that the pulp died. And so if I open that tooth up and I look underneath the microscope and I look down the canals, I don't see pulp tissue there. So that's a basic definition of necrotic or necrosis. Now, we don't use the term necrotic on previously treated teeth, and these are the teeth that have had a prior history of root canal therapy.
But someone with a tooth that's vital can certainly show up and be in a lot of pain.
Oh, absolutely.
Okay.
And you can tell because you can read their eyes. You know, eyes never lie. This is that one. The patient predominantly will come in and they'll say, hot and cold, more cold, it throbs, it beats like my heart, keeps me awake at night. I don't want to chew on the tooth. I can't put any temperature close to it without it giving me a problem. You know, and it's a lot of these teeth, they'll start off and they'll say, you know, I knew it was a little sensitive, and then it just progressively got worse. So it might be, you know, between a 1 to a 3 day process. Whereas a necrotic tooth that's infected can literally hit you overnight, and bam, you know.
Yeah. And pain is on your doorstep.
Oh yeah, before you even unlock the door.
Got it. Thank you.
You're welcome.
Hi, Dr. Gray. I have a question.
Uh-huh.
My name is Charles. I'm in Montreal, Quebec.
Yeah, yeah.
My question is, how deep will the solution go in the canal from the tip of the needle? Is it 1 millimeter or like 2 or 3, like you were mentioning previously?
It's generally within 1 to 2 millimeters beyond the end of the needle tip itself, and that's as far as it's really going to get. So that's why it's really important that you want to get your needle tip to within 2 to 3 millimeters of your working length. You know, the closer you get to your working length, the higher the incidence of that sodium hypochlorite accident. So you notice that I utilize that Irriflex tip. That tip you have to be really careful about. It's almost like that tip you probably as a general dentist may not really want to use, because I can get that to working length very easily, and if you're not careful, it's much easier to express solution beyond the end of the root. But because of the flexibility of certain needle tips on the market, even NiTi needle tips aren't as flexible as you really think inside the canal system. But you ideally want to get that tip within 2 to 3 millimeters of the working length. And I'll almost guarantee you probably 80% of the general dentists trying to do root canals out there today don't get anywhere close to the working length, because they don't understand those concepts.
Yeah, thank you.
You're welcome.
Hey, Rick, I had another question.
Sure.
That tip that you were talking about that's being sold through Dentsply, is that like a one-off, use it once and throw it away?
Yeah, well, technically it's a one-use product. Now, I have actually, autoclaved them, and you can get a couple of uses out of them. I really like the Swiss company. I like the guys behind that. They're also the guys behind the MAP system that we use. They're just super nice guys. I talked to him when I was in Dubai in February at ADEC, and he's actually kind of mentioned to me that they may be looking for a new source in the United States. They're not overly thrilled with Dentsply, so they may be looking for a different distributor here. But Dentsply got hold of it. So and it's not a cheap. They really marked the price up big time. It's like $70 for 20 of them. It's astronomically ridiculous what Dentsply marked that delivery system up to.
Thanks.
You're welcome. And I wish I could remember that. I know that the two files Dentsply is pushing right now are the next system, and I can't remember Bruder.
It's called True Shape. Bruder and Peters. Yeah. George Bruder and Ove Peters are, I guess, credited with designing it.
Yes. Let's talk about that just a little bit. That whole file system came out in 2008, and it was a bomb. It didn't take off at all. And
they've introduced it more times than I can count.
Yeah. Well, and they're reintroducing it now because ProTaper is not as popular as it once was, and they're losing a little steam on Wave, so they've got to dig into their archives to come up with files, and that's what they're doing. The next system has been around since 2007, so we're dealing with two file systems that have been around for a long time that are basically M-wire treated metal. It's not as flexible as they want you to think it is. Other questions?
I'll give you one, Dr. Gray. Hey, it's Jeff Pearson up here.
I'm sorry.
Oh, Dr. Gray, hey, it's Jeff Pearson up here in Minnesota.
Hey,
how are you doing today?
How are you, buddy?
Thanks for coming in. Yeah, I'm good. Say, so sodium hypochlorite, you buy your bleach at Costco, or you buy a 6% solution. How does 6% equal 100%?
Well, it doesn't, because there's no 100% bleach solution available. We just kind of call it 6% strength today. Now, you have to be a little careful, because the Clorox companies are starting to get a little smarter, and they're thinking, well, more is better. So now they're starting to introduce 8% and stronger. And what that basically means is the amount of free chloride within the system and how much is going to be in solution and that type of stuff. If it was 100% chloride in the solution, it would basically just be chloride powder. So you always have to have some type of a liquid medium in order so it can dissolve and saturate the solution.
So straight bleach is what percentage?
Straight normal bleach is 6%. Yeah, you can't.
Right.
You cannot buy diluted bleach in the store, or but you have to be careful too, because there's that higher viscosity bleach, what they call that splashless, which is more like a gel when you go to pour it. So you can't use that either. But there's a lot of clinicians that will basically run to Costco and get their bleach that way in those 3-gallon jugs.
Thank you.
I think I have a second question, Dr. Gray. Charles again.
Yeah, sure, Charles.
So on the step-by-step, so let's say you wait 1 minute. As soon as you remove the EDTA, you said you can switch directly to chlorhexidine after.
Correct.
No hypochlorite at all in between, right?
Correct. And you can rinse your EDTA out with the chlorhexidine.
Okay, perfect. Because the EDTA will not neutralize the hypochlorite, right? It's not the opposite. The EDTA
definitely neutralizes the hypochlorite, and that's why we use it. And the only reason not to go back in with bleach afterwards is just because of Marcus's study from 2010.
Okay, perfect. Thank you.
Any other questions? Okay, well, I think that's good for this session. Number one, let me know if you have any feedback on the level of the information and was this useful for you? And number two, if you have any ideas for future sessions like this, let me know. Email me after the meeting. And thank you, Dr. Gray, for putting this together, taking time out, because we know you're visiting there too in Colorado.
Yeah. Well, if you guys have other ideas, let's put them together, because we're all quarantined.
Yeah, we have some on the list, but I definitely want input from everybody. So let us know what would be most useful for you, and again, like the level of information or how it's presented. If you have any constructive ideas, let us know.
Okay.
Thank you.
Thank you so much.
Thanks,
Okay.
Gray.
Thank you, Dr.
Thanks,
Gray.
Dr. Gray.